Echoing on. Hi, everybody. Welcome to the September Survivorship Lecture Series, a lecture series from the Cancer Center, which features experts in different areas of cancer survivorship and cancer support. So today, very excited to bring the radiation oncologists. Dr. Christina Son specializes in using radiation therapy to treat patients with gynecologic cancers and breast cancers. Her clinical research interests include clinical trials, patient-reported outcomes, and quality of life. And also on the call, we have Dr. Mark Korpix, who treats a wide range of cancers, including head and neck, brain, lung, breast, GU, and GI. He has a strong commitment to clinical research, including participating in research trials, reducing the side effects of radiotherapy, and using imaging to improve cancer care. So, without any other delays except giving you screen sharing, go right ahead, Christina.
Okay, and let me know if are you guys seeing my presentation screen or like the background
It's the
one?
presenter view.
Okay, so I need to switch. Okay, how's that?
This looks good.
Great, thank you. Okay, so thank you so much, Debbie and everybody for inviting us to talk about radiation oncology and for joining us today. You guys are the most amazing partners to us, and not just rad-onc, but in oncology in general. I have so many patients who, want to talk to me about all these other, medical problems that they have, and I'm like, I'm so sorry, but you do not want me managing your blood pressure medications. So thank you so much for your partnership again. And hopefully today we can chat a little bit about what the patient experience is, just really briefly in rad-onc, and then talk about some of the things that you guys might be seeing in your clinics, so that at least you guys can kind of identify when it might be important to refer back to us or have us try to see them sooner, so that we can help manage some specifically kind of like radiation related toxicities. So, okay. So many patients, actually the majority of patients at some point in their cancer care do receive radiation. I will specifically focus on the patients who are receiving curative radiation, obviously for this audience, but many patients also receive palliative radiation. So since I think we have kind of like a mixed group of listeners today, I think just to clarify, the curative radiation, typically we are more aggressive. We have a higher tolerance for toxicity in this setting. And so in general, there's a higher chance of having side effects, higher chance of long-term toxicity. And this is because we're typically treating with higher doses in order to achieve cure, right? So basically how I explain this to patients, and cure is kind of also a very kind of nebulous term, but what I say is essentially we want the cancer to go away without coming back and never bothering you again ever in your lifetime, right? And then palliative radiation is more so intended for treatment of symptoms, which means that typically we don't need as high of a dose. We can go to a lower dose and still achieve a pretty good likelihood of some sort of symptom control. A lot of times the symptoms that we're targeting are pain, some sort of mass effect type symptom from a tumor. So that could be cord compression, bleeding. So tumors that bleed either into, for instance, like the GI tract, or you'll have gynae cancer patients who may have vaginal bleeding. So these are the types of, these are the types of symptoms that we're generally trying to help with. So again, I'll focus more on the curative patients for this discussion today. So As you guys have already kind of mentioned, there are different um, scenarios in which radiation is used. Sometimes it's the main curative treatment, so that would be the definitive treatment. So this is a lot of times patients you're seeing who have head and neck cancers, prostate, cervical cancer, anal cancers, lung cancers, and then many primary brain tumors as well. So this means that generally, again, radiation is the main treatment. The adjuvant, in the adjuvant setting, if radiation use is used, that generally means that after whatever their curative treatment is, which is typically surgery, they'll get radiation afterwards. And we'll kind of talk about what that mechanism is. And really the goal of that, the way I describe it to patients is it's supposedly to be an insurance policy is kind of what I say, right? So like we're reducing the chance of the cancer coming back in that spot or nearby, even though we think the surgeon removed everything that we can see. Neoadjuvant means that the radiation's being given prior or kind of before their main definitive treatment. So that would mean typically preoperatively. And this is again for the same intent of reducing the chance that it comes back in that area or a nearby area. And then consolidative is kind of another nebulous term, but essentially a lot of times these are patients who are maybe metastatic or have a slightly more advanced disease and are getting some sort of radiation as a means of a little bit of more durable kind of local control. So how does radiation therapy work? I won't dwell too much on this slide, but essentially the most common form of radiation is photon radiation. So that's the same X-rays that people are getting for diagnostic imaging. So the X-rays interact with water. It essentially causes free radical formation, and the free radicals bind to and damage DNA. And the idea is that cancer cells have more difficulty repairing their DNA compared to regular normal tissue. And so they are more susceptible to this free radical damage, and they are preferentially being killed compared to normal cells. So this is really the reason why we think radiation works, even though we do tend to treat normal tissue that's around the tumor as well. And it's important to know that all tissues have a tolerance level beyond which irreparable damage occurs. So that basically means that there's we have certain metrics that we use to ensure that we are not treating the normal tissue to quote unquote too much radiation. I should note here that there are other types of radiation therapy, but by far photon radiation is the most common. Some people also get referred for proton radiation, and I'll talk a little bit about that later, but that is also available in the Chicagoland area. So you may see patients who received that type of radiation. In terms of the side effect profile, it's essentially going to be the same. But there is some belief that due to the attributes of proton radiation, that there could be less damage to the normal tissue. So why do we do radiation, and what's its role kind of amongst all the different cancer therapies? So we know that, for instance, the blue represents some sort of tumor in the brain. The red may represent tiny microscopic cancer cells that are kind of floating in areas that are not necessarily super close to the tumor, but are still around. So the point of the surgery would be to remove the bulk of this tumor here, right? So the tumor is gone, at least that we can see with kind of like our naked eye and maybe on a scan. But these blue spiky areas indicate that there might be some kind of more infiltrative tumor cells that we really can't detect that are maybe still behind in that main area. So chemotherapy is kind of meant to, as I tell patients, it travels through the blood, goes where the blood goes, right? So it has a lot more of a body-wide effect compared to more local therapies. So we think that the chemotherapies may be able to kind of like sterilize some of these little red cells that are kind of scattered throughout, and then maybe decrease some of the burden of the blue spiky areas that were kind of more infiltrating. So what's the role of the radiation? The role of the radiation is to kind of eradicate any tumor cells that might be near this where this main tumor was, and to try to really get rid of any of that more infiltrating higher concentration of cancer cells that maybe the chemotherapy isn't really quite able to get as well. And as you guys probably know, not all patients get all three modalities. It really just depends on the disease site, location, extent of disease, all sorts of things like that. So all three definitely play a role in cancer treatment. In terms of the patient experience, so we initially start out seeing the patient in clinic as a consultation. The next step is, after we've kind of discussed with the patient what the plan is, we get a CT scan in our department, and that is essentially kind of hooked up to our planning software. So it's a normal CT scan. We just come up with different immobilization means to make sure that the patients are in the same place during each treatment. And then we get a CT scan with them in that immobilization. And then the patients come back for actual treatment. Treatment is generally daily, Monday through Friday. It can be as few as a single session or a handful of sessions, or it could be daily, Monday through Friday for up to 8 weeks, maybe even longer. Although nowadays it's all getting shorter. And then every week we see the patients while they're on treatment just to make sure they're doing okay, they don't have any issues, and manage any side effects. So many patients are kind of afraid because, they're like, oh, I'm going to get zapped, and is it going to hurt? And what I usually tell them is, no, it won't hurt when you're actually getting it, but it can cause side effects. And those side effects are cumulative, which means that at the beginning of treatment, they may kind of sail through like the first few weeks, or first few days, I'm sorry. They'll say, oh, this is nothing. This is great. This is so easy compared to whatever XYZ other treatment I've had. But I tell them, no, don't get too carried away, because it can definitely build up over time. The peak side effects are generally at the end of radiation or right after. A lot of times what we see is, for the patients, especially who have the very short courses of treatment, they are fine during the actual treatment. And then over the following weeks, actually, is when that inflammatory side effect of the radiation kind of causes issues. After radiation is done, we see the patients in follow-up, and this is really a multidisciplinary approach in terms of our follow-up. So typically most oncologists, and by oncologists, I mean the surgeon, the medical oncologist, the radiation oncologist, continue to follow their patients for a couple times at least. It depends again on the disease site, extent of disease, what the primary intent of the follow-up is. But for us, it's mainly to participate in the surveillance, regimen of that patient to detect recurrence if it happens, and then also to evaluate and manage any toxicity that could be related to the radiation that we're kind of responsible for. So a couple things that you guys might see in our notes that sound kind of like it's maybe not normal radiation. So stereotactic body radiation therapy, or stereotactic radiosurgery, those are basically kind of interchangeable. SRS is mostly used for the intracranial lesions, and SBRT is the term that's mostly used for areas in the rest of the body, so extracranial, but they're essentially the same thing, which is that we use a lot of really sophisticated technology to give really high doses to the tumor. It's, what we call very highly precise radiation treatment, and it's typically delivered in, anywhere from 1 to 5 treatments. And like sometimes people can get confused because they read stereotactic radiosurgery and they think the patient had some sort of invasive procedure or surgery, and it's not. It's just, that's kind of the term that's evolved. Brachytherapy actually is more invasive. So this is where we're actually placing a radiation source inside some sort of body cavity. It can be either a cavity that can be accessed kind of without any kind of like a very invasive incision type of procedure, which would be called intraoperative radiation therapy. Or it can be just placed kind of through the vagina, typically through the vagina or on the eye. or kind of for prostate cancer patients, it's placed, then there are needles that are placed through the perineum. So it is generally considered a little bit more of an invasive procedure, even if there is not an incision that's made. But the doses are very high. And the reason for that is that the whole point of brachytherapy is you get the radiation source right up against the tumor or inside the tumor. And you give a really high dose. And because your radiation source is so close to the tumor, the other tissues that are surrounding the tumor are relatively spared. And again, these can be temporary or permanent. So the most common temporary implants that you guys may see are prostate implants that are low dose rates, or LDR implants. And for those, when patients get scans of their pelvis, you'll actually see the little bright the brachytherapy seeds that are still there. But nowadays, many patients are also getting temporary prostate implants as well. So the whole point of both of these is to give high doses of radiation while sparing the nearby normal organs. So when we think about radiation side effects, the biggest point that I emphasize to all my patients is that the side effects are local, which means that, you know, everyone wants to know, am I going to lose my hair? And unless I'm actually treating your brain, typically, no, you would not lose your hair. So what the important thing to know for us when we are hearing about patient symptoms is to correlate it with what their actual radiation plan looks like, right? So, so this is an example of a patient who was getting prostate cancer treatment. And essentially, this is like a topographic map, which means that each isodose line here is a different color and corresponds to a different dose. So centrally, you'll see that the red is the highest dose that this patient is receiving. And then as you go further out, this magenta is kind of the lowest dose that all of this area within that line is receiving. So there have been many technical advances in radiation oncology. So one of the most important advances has probably been something called IMRT, which essentially means that instead of, for example, on the left, we have 4 beams. It's kind of a basic plan, I guess. We call it a 4-field box, which is exactly what it sounds like. So you have a beam coming from anterior, a beam coming from posterior, beam coming from the patient's right and the patient's left. And they all kind of converge in the middle into this kind of box-like shape. And they're treating this in this particular patient. The patient is receiving pelvic radiation to this area, but the actual target is this blue/teal green, pale green, sage color. And that's the actual target, but you can see that everything in the red is actually getting the prescription dose because it's kind of a rudimentary 4-field plan. IMRT is called, it stands for intensity modulated radiation therapy. Here, you can't see the actual beams, but the beams are coming from all over the patient at multiple different angles. It can get quite sophisticated. So it can actually be that each beam, as it's moving around the patient, is delivering the dose while the gantry is moving. And the actual beam shape is changing as the gantry is rotating around the patient. So it can get quite fancy. But you can see that here now the red is the prescription dose, and it is going exactly to the target and really nowhere else. So we can sculpt the dose a lot better to the patient's target nowadays, compared to techniques that were used more commonly even, 10, 15 years ago. So this is an example of the benefit of IMRT. Here we have an example of a radiation plan using brachytherapy. So this is a patient with probably a cervical cancer. You can see each bright spot here is essentially a needle. So you can kind of see on this sagittal view, there are needles going into the patient's cervix. And then there is also a tandem, which is going in up the vagina, through the cervix, and into the uterus, in the endometrial cavity. And this is how we can get really high doses here without having to push beam dose from outside the patient into this middle area. Here on the right, this is an example of SRS, which is stereotactic radiosurgery. Again, not a real surgery, but very precise treatment. So you can see that the dose is very high just in the areas of the tumor. The rest of the brain is relatively spared. So for a lot of patients who I talk to about this, I call it a spot treatment, right? So I'm not treating the whole brain, but just treating the areas where we can see tumor on a scan. So when we talk about radiation side effects, we generally divide it up into acute or late toxicities. And basically what that means is acute toxicities happen exactly what it sounds like during or right after radiation. Late toxicities can happen a few months later. The biggest difference between the two is that acute toxicity is generally temporary and the patients will recover from it, whereas late toxicities can be permanent and they can kind of occur really any time after treatment. And they can be severe. So that's just because there's constant ongoing response to the radiation that can lead to problems down the road. And it all sounds very scary, but one of our very senior attendings who is now retired, his favorite phrase used to be soft tissue never forgets. And then you may also hear what commonly what other people say, which is that radiation is the gift that keeps on giving. Right. So this is something that can be an issue for patients, years down the road. However, now that I've kind of scared everyone, and I tend to scare my patients too, generally severe late toxicities are not common. And I say that because a lot of times, and it's no one's fault, but a lot of times I'll see notes where, they'll attribute some patient symptom to radiation, and we're like, oh, that we didn't even treat that area. So just so that it is not super common for there to be these really horrible radiation toxicities in this modern era. Certainly many years ago, I'll have patients who say that they haven't had an uncle or a parent who had radiation 30 years ago or something like that, and they were horribly disfigured or had some sort of major issue. And yes, those things did happen and probably still do happen, especially in certain disease sites, but they're not common. So again, we'll focus on late toxicities because typically that's where you guys will be seeing these patients. Lifestyle modifications to mitigate toxicity, the number one thing is smoking cessation. And we know that smoking itself is related to soft tissue necrosis and radiation necrosis. And so I always try to encourage my patients, I'll always try to ask, hey, are you still smoking? And try to gently explain that the side effects can be a lot worse if they continue to smoke. And then also we know cardiac toxicity can be affected. And then also smoking has been related to increased rates of tumor recurrence in various disease sites. So this is all very important for patients. So in terms of radiation toxicity timelines and everything, so this is an example of an actual handout that we give to patients, and we have these for multiple different disease sites. And essentially, it divides up the radiation toxicities into short-term, which is the acute toxicities, and long-term. And then we explain to the patient that the larger the circle, the more common the side effect, the smaller the circle, the less common. So you'll notice that, for example, secondary cancer is the smallest circle, but again, it is a long-term toxicity. And secondary cancer is something that you guys may see or think about in the pediatric population or our very young patients who get irradiated. And while it's still rare, it certainly happens. We know it occurs. There's not much we can do, except we'll kind of talk about in some of the later slides that screening for different cancers may be affected by things like prior radiation or genetic syndromes. Again, the effects are local. So this sheet is for patients who were treated to the pelvis for gynecologic cancers. And you can see exactly why, based on this radiation plan, you can see what area was treated, and you can see that it corresponds to the different side effects that you can get, right? So urinary issues, bowel issues, other bowel issues, and decreased blood counts is something that happens sometimes in patients who get large amounts of bone marrow that are irradiated. So it's not necessarily the most obvious thing, but typically it's not sufficient enough to cause severe or prolonged cytopenias. That's more of a concern for patients who especially are getting concurrent chemotherapy, and that's typically, again, temporary. It's not very common for patients to have permanent cytopenias from radiation therapy in this kind of day and age. Ovarian failure is something for our younger patients who are getting irradiated to the pelvis that we do need to consider because that can, of course, have systemic or distant effects rather than local effects. So I wanted to actually start out talking about breast cancer because it is so common, and and nowadays, we have many breast cancer patients who are living a very, very long time, thankfully. So this is something that we are seeing patients who are years and years and years out from treatment now and having potentially effects of radiation and surgery. So the most common things that come up in the long term for my breast cancer patients are really going to be more the cosmesis fibrosis that can occur in the breast tissue. So typically after radiation, what I've been offering to some patients, I would say to most of my patients, not necessarily every patient, is vitamin E and Trental. Those help increase blood flow and have been shown to decrease fibrosis in some breast cancer patients. And then also, I always discuss with my patients that if they are concerned about cosmesis, they can always see a plastic surgeon. That's typically covered by insurance to the extent that, a patient's insurance plan is individualized to their, whatever their copay, deductible, et cetera. But this is open to our breast cancer patients. And then lymphedema, range of motion difficulties occur after the surgery and radiation treatment that patients are getting. My first step, and you'll probably see this throughout the presentation, for many side effects of radiation is basically to refer them for physical therapy. We love physical therapy. They are also amazing partners to us. So I have a very, very low trigger to refer to them. Compression garments are important for these patients as well. Referral to plastics. Sometimes for the really severe lymphedema cases, there are some interventions that can be done to try to help mitigate this side effect. And then optimizing weight, exercise, those kinds of things can also help. Talk about pneumonitis in more detail in the next few slides, but this is something that can happen because the lung is right behind the breast tissue and does get a little bit of radiation. It's not as common for patients to have chronic breast or chest wall pain after radiation therapy, but certainly can happen. I have one patient that I can think of right now who has severe enough chest wall pain after radiation that she sees multiple different physicians and providers to help manage this and is on a few different medications for it. So again, it's not very common. What's more common is for people to have kind of this chronic low-level soreness in the breast. Again, that's not super common, but it is a little bit, a lot of patients talk about that, especially within the first year or so after radiation and surgery. Not common to have necrosis, rib fracture. The other main thing is that, of course, we want to rule out recurrence anytime someone presents with a pain type symptom, especially in the area where they've had prior radiation, which is typically an area where there was a tumor before. So the problem of pneumonitis applies to basically any patient who gets radiation to their lungs. So it doesn't necessarily mean it's a lung cancer patient, right? So anyone who's getting radiation to their esophagus or to the breast can have enough dose to their lung that they may develop pneumonitis. So this is a case of a woman who was treated for breast cancer. This is her radiation plan. About 5 months after radiation, she started developing kind of this dry cough, some shortness of breath. Her PCP prescribed inhalers and Flonase. She had a chest x-ray done that showed pneumonia, and so she got antibiotics. She had some other workup done. COVID and infectious testing was negative. And then she messaged us basically saying, or her daughter messaged us saying, my mom's been having these symptoms. What do you think? And so based on the time frame, we ordered a CT scan of the chest. It showed what they described as the consolidation, opacity, and organizing pneumonia. And we started her on prednisone, and she had an improvement in her symptoms. We had a lot of difficulty actually tapering her off the prednisone. We ended up referring her to our pulmonary colleagues who were helping to kind of manage the prednisone taper and her symptoms. She was eventually able to be stopped, and the prednisone was discontinued 7 months later, and she's now doing completely fine, completely asymptomatic. Although if you scanned her chest, you could probably still see the remnants of this kind of, quote unquote, radiation damage, I guess, to her lungs. But the reason why I have both her radiation plan and her actual scan up here is you can actually see where the radiation was given almost, right? So you can see that at the left lung apex that there is this abnormality here on her diagnostic scan, which corresponds to the radiation dose that was given to this area. And then also on this coronal view, you can see, again, the apex got some radiation, and then right along this lung chest wall interface, there was lung that got enough radiation dose, right? So you can kind of see that mirrored right here. So that's an important component of evaluating these patients, is to see where the diagnostic imaging changes are and whether they correspond to where there are high doses of radiation. So again, radiation pneumonitis is something that can occur in anyone who's had radiation to their lungs, even if it's not for a lung cancer. Usually what the classic teaching is that it happens 6 weeks to 6 months after radiation. That's what I tell my residents. The symptoms are very similar to what may be like an infectious pneumonia. And so they could have fevers, even low-grade fevers, cough, dyspnea. And then on exam, they can have kind of these non-specific findings. And the other important thing is when you're doing a workup for this is, of course, to make sure that there isn't recurrence in the lungs. And it's also important to compare it with the radiation plan, as I mentioned. So the treatment is oral glucocorticoids. There are options to do inhaled, but typically if someone is coming with symptoms, it's enough to do kind of oral medications. So let's switch gears to talk about prostate cancer, another very, very common cancer patient population that we see. So we do know that radiation and surgery can affect various pelvic organs. So the most common symptoms that men have after radiation or surgery are changes to their urination, their bowel habits, and sexual function. And so these are some patient quality of life scores that were reported after this randomized trial that looked at radiation versus prostatectomy versus active monitoring for patients. The radiation is in the yellow, the prostatectomy is in the red. So the reason why I have this is because I'm not trying to compare the two modalities. It's more so to show what happens to patients after they receive these interventions. So for instance, this is the question of the proportion of men who are using 1 or more pads per day. You can see that goes up quite high after surgery. So prostatectomy is in the red, and then it kind of comes back down. Radiation, you may notice a slight difference, but it's generally not as impactful as surgery is on the urinary kind of incontinence. And then again, you can see there's a urinary score that this particular patient-reported outcome kind of calculates. And you can see that the score kind of dips right around the time that the patient's getting treatment and then kind of somewhat normalizes. But again, surgery can impact the urination as well. or more so actually than the radiation. Sexual function is impacted both by radiation and surgery. I should mention before I forget that prostate cancer patients may get combinations of treatments, right? So not only are they getting radiation, they can get radiation after they've had a surgery because there's some sort of PSA recurrence. And then a lot of times these men are also getting hormone therapy, right? So hormone therapy is going to be one of the biggest things that impacts sexual function. And there are studies that show that recovery from hormone therapy can take a long time, like up to a year or more after the patient has stopped receiving hormone medicine. So all of these kind of should be taken into consideration when considering how to manage a patient's sexual function as well, because there may be better or worse interventions depending upon the reason why a patient is having sexual function issues. So, for instance, if someone's getting hormone therapy and they're having trouble with their sexual desire, there isn't as much that we can do for that compared to somebody who can have some sort of other intervention. In terms of the bowel function, we know that radiation actually has a little bit more of an impact on bowel function compared to surgery. And this shows the bowel patient-reported outcome score. And you can see that with radiation, it dips a little bit, then it gets better, and then kind of gets close to normal, but maybe not quite normal. And that's kind of exactly how I describe most radiation symptoms to my patients, where I'll say, you may notice this symptom, it will get worse right after or right towards the end of radiation. And then the majority, the average person, their symptoms will come back to normal or close to normal after, in the weeks, months, years after radiation. And then I always tell patients that's the average. So you may be better or worse than the average. And most patients kind of understand that language. So when we think about pelvic radiation, we already kind of mentioned some of these things, but some of the specific symptoms that patients can have: urinary incontinence or bowel incontinence, cystitis, and that can be hemorrhagic cystitis or just kind of more irritative type symptoms, abdominal pain or diarrhea, proctitis symptoms that can result in this feeling of urgency or tenesmus, ureteral stricture or urethral stricture, even depending upon the area that's treated. And then less commonly, things like small bowel obstruction, bowel perforation or ulceration, fistulas. So when we're evaluating these patients, most important thing, depending upon the time frame, usually when we think about recurrences, they can happen typically they happen within the first 2 to 3 years after treatment or after diagnosis, but this is the most kind of important thing to rule out and ensure that we're not missing a cancer recurrence. Pelvic symptoms, like I mentioned before, this is kind of a wordy slide, I'm sorry, but it kind of briefly summarizes the interventions that we can use for these symptoms. Like I said, physical therapists are my best friend. So anyone who has any sort of bowel bladder symptom, generally I'm referring them to pelvic floor PT. And I'm sorry if we are all contributing to their being super overloaded and overworked, but this is a really, really helpful resource. And then referral, of course, to our colleagues for pelvic floor issues. And then radiation cystitis kind of depends upon what their symptoms are. There's certainly kind of medical interventions and then more invasive interventions that our urologist colleagues can consider depending upon what the symptoms are and how severe they are, of course. Chronic abdominal pain and diarrhea, that is a harder thing to manage. Usually I'll try to manage it initially myself and then eventually we'll send them to GI. Especially because, I have had some patients who kind of have these IBS or IBD type symptoms and they've never really been worked up. So I do eventually get people over to GI if I can. Radiation proctitis, again, we generally use enemas for this initially. And then if there's bleeding or more severe symptoms, I'll send them to GI for intervention. Same with ureteral or urethral strictures. And then again, especially for these small bowel obstructions, perforation, ulceration, all this stuff, it's important to rule out recurrence and then of course send them to the appropriate physicians to manage. So specifically when discussing GYN pelvic radiation, so these are for I mentioned some of this before. Ovarian dysfunction can have a lot of impact on a patient's quality of life. I don't personally do the hormone replacement therapy discussion, but our gynocs historically have done a really amazing job of kind of helping to manage this for the patients, and it can really help with quality of life. Vaginal dryness and atrophy, generally, vaginal estrogen is the answer to that. I will say that there's some concern in patients who have endometrial cancers that are hormone mediated. So our ER positive endometrial cancers, endometrioid histologies, there's that theoretical concern that that estrogen in the vagina can increase recurrence risk. This has not really been borne out by the data, and actually all of the gynonc societies they do recommend vaginal estrogen for most of these women to help mitigate symptoms for sexual function. Vaginal stenosis is something that happens after radiation. We provide everybody in our clinic with dilators, anyone who has had pelvic radiation, even if they don't have a gynecologic cancer, right? So we generally try to offer pelvic radiation, vaginal dilators to these women if we can. And then pelvic floor PT, of course, they help with this a lot. Sexual function can be so multidimensional, especially for women who have had gynecologic cancers. So pelvic floor physical therapy is an important component of kind of the physiologic changes that can occur, but also psychotherapy. And at University of Chicago, there's a sexual function clinic there that's called the PRISM Clinic. So these are also really important resources, I think, in trying to help people kind of regain their sexual function after a cancer diagnosis and cancer treatment. I kind of already talked about this, but it's quite common in patients who have undergone treatment for prostate cancer. And then head and neck radiation. So this can be challenging. It can be quite morbid depending upon the area that's being treated and the dose, et cetera. Some of the common long-term side effects are going to be changes in their taste, dry mouth. There are some interventions that can be done, but sometimes there's somewhat limited efficacy depending upon how severe the symptoms are. Fibrosis, trismus, esophageal or laryngeal stenosis or dysphagia. Again, our speech swallow therapists can help kind of evaluate these patients. Lymphedema can happen in the neck, osteoradionecrosis, which we'll talk about, hypothyroidism. And then, of course, it's less common, but of course, very scary to think of damage to the nerves or the brain or brainstem. And at that point, I think specialist referral would be called for. So osteoradionecrosis can happen in the weeks to months after radiation. Generally, it's like a non-healing exposed necrotic bone within the irradiated field. And it can occur spontaneously, but most often we see it after patients get dental extraction. So you may see this in the notes or here, but essentially patients who may need dental procedures, we encourage them to do it before the radiation. Treatment is debridement, antibiotics, again, vitamin E and Trental, which I mentioned before, we use for breast cancer patients to prevent fibrosis. Then hyperbaric oxygen. So then a quick note about hyperbaric oxygen. This isn't available everywhere, but it is available at this institution here. And the mechanism is that increases oxygen to tissues to help promote angiogenesis and wound healing. So I don't know if this is exactly the setup that we have at UIC, but a lot of times patients are in this pressurized chamber. It does take, I think it's quite a few treatments, maybe 20 to 30 treatments or so. So it is a commitment on the part of the patient, and a lot of patients can't do it, but But it is an important tool, especially for patients who have more severe radiation side effects, such as necrosis or really severe radiation cystitis. So I wanted to talk about cardiac toxicity in the last few minutes, and that's because this is a really important area that's been evolving as the radiation technology has changed. Now there's even an entirely specialized field of cardiac or cardio-oncologists, oncocardiology, cardio-oncology. And that just goes to show how important this is for our patients, especially, we have patients who are receiving cardiotoxic chemotherapy and then also getting radiation to that area, their chest or thoracic cavity. So it's really important, I think, to be able to involve the appropriate physicians and clinicians. So acutely, you can have pericarditis, but even this is not very common. It's mostly like the late toxicities that we're worried about, so ischemic disease or valvular disease and cardiomyopathy. So in terms of the actual risk of toxicity from radiation, this is a study, I think this is like a Danish registry study. It showed when they were comparing patients who had left versus right-sided breast cancer. This is kind of like a natural study and looking at the impact of radiation, right? So they do find that there was some increased incidence of radiation, of ischemic heart disease in patients who had left-sided breast cancer, and were presumably treated with, left-sided radiation. And then some data has come out showing that they were kind of able to quantify the relative risk increase for every gray of radiation that's given. Gray is the unit of radiation. And there are some issues with this study. Many people will say that it's based on extremely, old data. But it is a way to kind of quantify that risk. And then just to kind of review how the older techniques were, sadly I can't really even describe what's happening here because I never learned how to do this, but essentially they would take what amounts to x-rays and kind of like draw on them and calculate some sort of radiation, dose delivery. And this is kind of how they deliver the radiation. So it's hard to even know whether the dose that they're extrapolating from the dose of the heart or the lungs is how accurate those are. But this is kind of the old school way of that they used to do radiation, even as late as the 1990s, it looks like. So this is reassuring. This is actually looking at, again, left-sided versus right-sided radiation for breast cancer patients, but looking at actually the era in which they were treated. So you can see in the older era, so treated before 2007, that the left-sided patients, so patients who had left-sided breast cancer and got subsequent left-sided radiation, seemed to do worse in terms of cardiac events. But in the more modern era, where we're using modern radiation planning, 3D planning, getting CAT scans on patients, it doesn't really look like there's a significant difference between left and right-sided radiation patients. So that doesn't mean to say that there's no impact on our breast cancer patients. A lot of it's going to depend on the anatomy of the patient, what kind of radiation planning technique was used. But it is reassuring that we've gotten better at this. So now we have multiple different ways of setting up patients, of planning patients to help reduce dose to the posterior area behind the breast tissue. So deep inspiratory breath hold is where we actually deliver the radiation dose while the patient is holding their breath. And what happens is that the heart actually moves down and out of the radiation field more than it would typically. In prone breast radiation, we have the patients on their bellies, and then there's like a hole in the board for their breast to fall through. It's kind of similar to how breast MRIs are done. And you can see that we can do a really good job of preventing dose to the lungs and heart here, because there's just essentially a straight line that treats the breast tissue and not really significantly anything that's posterior to that. IMRT is now also being more used for breast cancer patients. What can happen is we can sculpt the dose better, but there's not kind of that same straight line in terms of the dose distribution. And then proton radiation is what I discussed earlier, where there's some theoretical benefit in terms of the dose distribution there. Also, in terms of how we're doing, not technologically, but kind of how the field is advancing, there's more data to support partial breast radiation, which means that instead of treating the entire breast, you just treat the area that's around the lumpectomy cavity. And that obviously can reduce dose to heart and lungs depending upon the location. So this is just another slide kind of demonstrating how lymphoma treatment has changed over time. Lymphoma was the other major cancer where there was contribution to cardiac, long-term cardiac issues. Again, fields have been getting smaller and smaller over time, and planning has also improved over time. So risk reduction, it's all the kind of normal stuff that I'm sure you guys and other internal medicine docs and family medicine docs are talking to their patients about: smoking cessation, lifestyle factors, regular follow-up with PCP and or cardiology, and then cardio-oncology. So Stephanie Tawari, who I've never met in person, but she helped provide a couple slides kind of looking at or reviewing who to refer to their cardio-oncology team. So anyone, I think the main thing for this audience would be anyone who needs assistance with managing cardiotoxic effects of oncology treatment and any new cardiac symptoms during or after cancer treatment. And the main way to get in touch with them is to put in an ambulatory referral and to message them via Epic Chat. So cancer surveillance is the other really important component of seeing these patients in follow-up. I think NCCN guidelines would be kind of the main starting point for frequency and, information about what kind of surveillance is needed for different patients and risk groups. This is generally what we follow in our clinics. And then the normal routine health maintenance and screening. So I definitely have to remind my patients to go back to see their PCPs because they are probably due for a colonoscopy or a mammogram, and or they have also other medical problems that they just haven't really dealt with because they've been so focused on the cancer treatment. And then, of course, genetic syndromes can alter the cancer screening schedules. And I think our genetic counselors here are great and often are able to be really good resources for this. So in conclusion, most patients have only mild to moderate long-term effects from radiation. It's important, especially with chronic pain type of symptoms, to rule out local recurrence. And then, and also, please feel free to message us or refer back to us for any patients who you think could have any chance of having any sort of radiation toxicity. And again, thank you so much for being our partners and caring for these patients. They've been through a lot. And we obviously are not great at managing things that are outside our wheelhouse. So we love that you guys are able to partner with us to help us with these patients.
And same to you, Christina. Thank you so much.
Thank you, guys.
You have this wide breadth of knowledge, and this has been an enlightening talk. And I particularly enjoyed where you talked about kind of the history of radonc and how things have evolved over time.
Yeah.
And I just had a quick question before I can open it up for a couple minutes. Given the evolution of radonc, I know new types of treatments for cancer are coming down the line. What do you see as the future for radonc in treating cancers, like say, like 5-10 years down the road? How do you think it may change?
Yeah, I think, well, a lot of things. I think more and more we're getting to, we're trying to identify the patients who will really benefit from radiation outside of what our historic, clinical pathologic risk stratification schemes have been. So I think we'll hopefully get better and better at that. In terms of the technology, now we're doing a lot more. There's a lot more focus on the benefit of protons and also adaptive planning. So when the patients are actually on the machine now, some places are modifying the radiation plans in real time based on how the organs are, the location of the other nearby organs while the patient's on the table. It's extremely resource intensive and personnel intensive, but this is hopefully where we're going, where we can try to really optimize the risk benefit profile for patients. So.
Mm-hmm. Yeah, that's always the goal.
Yes.
Does anyone else have any comments except for the thank yous in the chat? Appreciate that. Christina appreciates that. Dr. Ganshow, did you have anything to say?
Yeah, sure. Thank you, Christina. This was excellent. We have a couple of, I don't know if we have two
Sean's
faculty
on.
is joining us this year who are primary care doctors who are training in cancer survivorship and cancer prevention. And hopefully they'll come and shadow with you for at least a half of a day, but really trying to sort of expand what we're doing into the primary care space. But here's my question for you. So I just want to make you aware of that because I forgot to say that at the beginning. We often see the head and neck patients, after or during after they've completed therapy, or sometimes we will see patients who are in active therapy. And, we follow some of the NCCN surveillance guidelines and follow-up recommendations, which for head and neck patients often include a hormonal evaluation for those who have received radiation to the base of the skull. And I'm never quite sure how to figure out if they got that, right? How to go back through the notes and wondering if there is attention being paid to specifically highlight that, because you guys, as we mentioned at the beginning, have these amazing notes that are so comprehensive, but that's I sometimes struggle to find.
That's a great question. I don't know that you'd necessarily be able to find that. I think so you've seen our completion summaries, right? I think hopefully, they usually have screenshots of the radiation plan. Sometimes it's really tiny though, and you're not at the level where you can actually see higher up, like at the base of skull. I don't know if I guess I don't know cost effective and time effective, like whether it'd be reasonable to have some sort of like screening labs type done. I'm not really sure. And I don't know if Mark is still on, if he can comment on this.
So it's the questions about surveillance for patients who had base of skull radiation.
Yeah, hormonal. Sorry, go ahead.
Yeah, NCCN recommends surveillance of that. The trouble we have is sort of figuring out who actually got that, right?
So, I mean, yeah, like Christina was saying, we do have pictures in our completion summary. And then, yeah, I don't know. I guess it basically depends more on the site. Like most nasopharynx cancers are going to have some base of skull radiation, but we can try to make note of that.
Yeah. Okay, but that's good to know. So, patients who get nasopharynx cancers probably or get radiation for that are probably going to be eligible for this, right? It's sort of the other one. Are there other common head and neck cancers that where the base of the skull is typically radiated?
Maybe sinonasal cancers as well.
Okay.
But
Okay.
a lot of
Yeah.
what we see is like hypopharynx and larynx cancers, and those probably aren't not getting base of skull radiation.
Okay. Those principles are really, or sort of, summaries are really helpful for us. Thank you, Mark.
Pam,
And we can always reach out to you too.
Oh,
yeah.
Sorry. Go ahead.
No,
Yeah,
I'm done.
reach out to us anytime if you have questions. We're happy to talk.
I was just asking, Pam, were you asking about like surveillance for like hypopituitarism? Is that like
Yeah.
what you're asking about? Okay.
Yeah, I mean, it seems to be, it's now a category 2B recommendation. It sort of was in there a little less stringently, in terms of the recommendation in the NCCN guidelines for the follow-up recommendations. But yes, that's what we're getting at, right? Is sort of that hypo pit.
So I know, at least for me, anytime the pituitary is getting radiation, I put in an endocrinology referral. I don't know what Dr. Koshi does, but probably similar. So yeah, if you see an endocrinology referral, it probably means we're worried about hypopituitarism.
Okay. All right. That's really helpful. Thank you.
Great. Thanks for the discussion. It is after 10, so I'm going to let everyone go at this time. If we have any further questions, definitely feel free to email Dr. Son, Dr. Corpix, myself, Dr. Yanchow. We are all available. Thank you for attending today.
Thank you.
Thanks, everybody.